I'm Michelle Wills. I have a long history in immunisation. In fact, I look at some people in the room and think, I've probably been working in immunisation longer than you've been alive, let alone nursing. Some of us go back a very long way in doing immunisation together, don't we, Belinda? So I've worked in all aspects of immunisation. So I did my training at the Children's Hospital. So I worked in the immunisation clinic there before it was an immunisation clinic. It was just a little desk in outpatients before they had this whiz-bang drop-in clinic. I've done vaccine research, and then I found these wonderful things called primary care organisations. Back in those days, they were divisions of general practice. So I've worked for divisions of general practice, Medicare Locals, the state-based organisation, and the national organisation helping general practices with immunisation. And more recently, I now work 2 days a week at the Department of Health and Human Services in the immunisation section. And I also run the La Trobe Nurse Immunisers course. So I have this big passion for immunisation, and I think it really stemmed from the fact that I actually worked at the Children's Hospital and saw what vaccine preventable diseases did to children, and why would you ever do that when you can actually vaccinate against a disease. So that is my big thing. So can I just ask, is anybody here a nurse immuniser? Look at you all. You could be standing up here doing it. So yes, I'm just going to reinforce for you probably what you already know. For those of you that it may be new for general practice, or maybe even working in aged care or something, has anybody not immunised a baby before, actually given an injection to a baby? Okay. I sympathise with you because that's fine. When I first walked into general practice, they said to me, could you do an ECG? And I went, he's 65, he's got hairs on his chest. How do I do it? Because I was so used to just doing ECGs on little babies. So everybody has their own skill set, and it's just a matter of gaining your confidence in being able to do it. And there is a bit of a skill in actually immunising children, because it's not just the child, you have to worry about the parents as well. So it all gets better with practice, and also if you have the chance to watch other people doing it, just watching what their tips and techniques are. So with that, let's get started. I talk quickly, I know, so please just tell me to slow down if I'm talking too quickly for you. I'm going to read off here because I'm going to get a sore neck if I have to keep looking at the slides. So by the end of this, because I'm so fabulous, you're going to know everything about immunisation that you need to know for the general practice setting. Well, hopefully we will. We're going to talk about the Australian Immunisation Register, the National Immunisation Program, the management of vaccines, so talking about cold chain, pre-vaccination screening, informed consent, vaccination techniques and procedures, post-vaccination management and common reactions, identification of anaphylaxis, and vaccination for special groups and catch-ups. And they've only given me 2 hours, so let's see how we go. For this presentation, because we are filming it, I'm going to keep it fairly general as I possibly can. Then at the end of the presentation, I'm going to talk about the very specific state-based programs that we have here in Victoria that will impact you. So why do we vaccinate? Because we want to protect the community. And we do know that there is a small percentage of the community that can't be vaccinated due to their age, they've got a medical condition or whatever. So we're actually looking to get the most of the community protected, and that's called herd immunity. And if you need a concept of how to see this, there's a great video called Chain of Protection, and it's just chainofprotection.org, and it gives this concept of protecting young babies that are too young to be vaccinated and having everybody around them actually vaccinated to protect them. And they do it with different coloured t-shirts and things like that. So it just shows if you've got the majority of people around you that are immunised, then that baby's protected. But if you've got people visiting that baby that aren't immunised, then that baby's potentially exposed to some of these vaccine preventable diseases. We do know that there is no vaccine on the market that's 100% effective, so we can never say that we're going to give you a guarantee that there's 100% efficacy in a vaccine, but what we can do is minimise disease if there is breakthrough disease. So different vaccines have different efficacy, so some of the vaccines will give you 85% efficacy, some will give you 95%. It all changes with the different vaccines. They're safe, but they're as safe as any medication. There is no medication in the world that you can offer anybody that doesn't have a side effect profile. And when you tell parents that, even if you look up the side effects of Panadol, there is a side effects profile on that, they're like, oh. So what we're trying to do is promote the safe giving of the vaccines and the safety of the child by having this vaccination. We do various things. So we have a vaccine schedule. So over the last few years, we've really moved from just a childhood schedule. We've added a lot of school, so adolescent vaccines, and now there's a lot more in the adult realm. So we've now got Zostavax for the oldies as well as the over 65. But what we do, we may have a national immunisation program, and the national immunisation program is the government-funded vaccines, but we also make recommendations to other people, and this is where Halo comes in, where you've got an adult that comes into the practice. So we need to talk to them about their health, their age, their lifestyle, and their occupation, and there may be vaccines that we're recommending for those people, but they're not necessarily funded. And we'll look at those a little bit later on in the presentation. For vaccination, if you're not a nurse immuniser, you're looking at working within your scope of practice. So it's the same as giving any drug. If someone asks me to give an antibiotic I'd never heard of, I go and look it up. I need to know what the side effects and things are. This is exactly the same for you. You're all nurses, you need to be working within your scope of practice. So you need to understand the side effects and the benefits of the vaccine so you can discuss that with either the parents and guardians of the children or with the patient themselves. There are lots of things that we can use as immunisation providers to help us in our journey. So Myths and Realities is a book that's actually been written specifically for immunisation providers to help with these wonderful myths that we've got going around about vaccination. So I'm sure you've all heard of the Wakefield study where he supposedly had my word is just gone, a link between autism and the measles vaccine. And so this was a very flawed study that has been disproven numerous times with various other studies, but that has left a lingering legacy for a lot of people. So, and it's just gone from MMR vaccine causing autism to all vaccines causing autism. So you have a lot of parents that are really scared about vaccinating their child because they're worried about the effects that could potentially come. So we've got this Myths and Realities, and it's very good. It actually addresses most of the concerns the parents have. So MMR and autism, there was a thing for a while, something about hepatitis B, all of those things are in there. So it's a book for you, but if you've got a parent that needs to look at it, they can as well. It's just available from the Immunise Australia website. Currently, the Immunise Australia website, where we get all these resources from, is actually under reconstruction. So it's a beta testing site at the moment, which is a bit annoying, but you can move to their new website, but it's just probably a little bit difficult to find their resources at the moment. So you may have to ring them up to say, you know, can you send me a copy of this book? Or most of their resources you can actually download as PDFs anyway. So it's important that we do try and address the myths, because people aren't going to get vaccinated if they believe. They're not going to harm their children. So they're going to try and do the best thing for their child, and if they think that means not vaccinating, that's what they're going to do, and obviously that's not what we want. Okay, so let's talk about actual vaccinations. So vaccines are fragile biological substances. They don't like to get hot, they don't like to get cold. A lot of them don't like to be exposed to light. Some of them are live, some of them are inactivated. We have conjugate, we have polysaccharide. There's a whole realm of things that you need to know about immunisation. And that's why in Victoria we're very lucky, because we have, as part of our immunisation schedule, we talk about all of these things, such as whether the vaccine needs to be reconstituted, where to give it, and we'll deal with having a look at that schedule at the end of this talk. So as registered nurses that are not nurse immunisers, you will be administering these vaccines on behalf of the GP. So as a nurse immuniser, you can give the vaccines on your own, you have the authority to do this. But if you are a registered nurse or an enrolled nurse working in general practice, then you need to have a doctor's order to administer this vaccine, and you also need to have the doctor stay on the premises for 15 minutes afterwards in case of anaphylaxis. Nurse immunisers are actually authorised in Victoria to give adrenaline. There's different rules in different states because everyone has different drugs and poisons laws because we're a federation. So you need to know wherever you're working what your rules are. But here in Victoria, the nurse immunisers can give adrenaline, but the registered nurses or the ENs need to have the doctor on premises. So there's no point in him writing the order, you giving the vaccine, and he's just nicked off down to the nursing home to see the patients. He needs to be there in case there's anaphylaxis.
Should I save questions till later?
Oh, you can ask now and I'll repeat the question.
No, I'll just save it. I'll just write it.
Oh, okay. So we're going to have questions later. All right. Okay, so legislation. So vaccines are S4 medications, and that's just how you have to look at it. As nurses, we're all used to dealing with S4 medications, so that's what we have to do. And it's why vaccines need to be away in fridges, either a lockable fridge or a lockable room, because they are S4 medications. I think I've said most of this because I preempt myself, and I do that quite often with my slides. It says all non-medical vaccination providers are required to renew their CPR certification annually. I think everybody, whether you're doing vaccinations or not, should have an annual CPR. For the nurse immunisers, they're also required, not by legislation or anything, but they need to keep up to date with their scope of practice, and I think everybody should do this by going to an immunisation update and especially looking at managing adverse events following immunisation. That's a really big thing. So as I said, every state has different drugs and poisons acts, and we are moving towards a national qualification, but it makes it really difficult when every state has different laws. Here in Victoria, ENs cannot become, even medication endorsed ENs under legislation cannot become accredited nurse immunisers. Other states they can. Other states have Aboriginal health practitioners are actually able to become accredited nurse immunisers. So as you can see, it causes a bit of a dilemma trying to work all of this out. So we will get a national qualification one day, but I'm not quite sure when that's going to happen. Okay, so this is our Bible, is the Australian Immunisation Handbook. And you've probably got one of these around your practice somewhere. It's out of date. Okay, so the printed copy is now out of date. I love my printed copy because I know where everything is in it. So what I have done, and I suggest for people that don't have reliable internet access because everything is online, is that you check what the online updates have been and then mark it into your book. And so that way you know that you're looking for something new. Otherwise, I really suggest if you've got reliable internet, that you only use the online version of the book. But if you don't, make sure that you mark the updates in the book. When you go into the online thing, which is actually under beta testing at the moment as well, so it's about to be updated to become more friendly. At the moment, it's sort of like PDF versions, and it takes quite a while to scroll through. We'll be able to, the updates are at the front page. So as soon as you go into the immunisation book, there is a thing saying when the updates were made. And there's just, there's about 40 updates since the book was first printed in 2013. So it's really important that you're looking at these updates. Currently at the moment, as of where are we now, March, we're still waiting for the Gardasil chapter to be updated because it's still only talking about the 4-HPV vaccine, not the Gardasil 9, and we now need the influenza chapter to be updated with the new over 65 influenza vaccines that are coming through. So for those two products at the moment, we're using the ATAGI advice, which is the Australian Technical Advisory Group's advice, and then eventually it will get into the handbook. So we just have to be really careful. But as soon as you print something like this, it's out of date. I mean, if you've been working in immunisation for any length of time, you know the number of changes we've had even just in the last 2 or 3 years. We have the advisory group on immunisation at ATAGI, so they're the group of experts that meet every couple of months to decide what should be on the program, what vaccines we need to give, looking at the trends in epi. So do we need to bring something new on, such as meningococcal ACYW? What are we doing with flu? We didn't have a particularly great flu season in 2017, so they look at things like that. Then we also have NCIS, which is the National Centre for Immunisation Research and Surveillance. They have an amazing array of fact sheets for health professionals, and we will look at those later. And also for parents, they have things like the MMR Decision Aid. It's a really great site to have bookmarked. I have it bookmarked and use it constantly. And then you have your state health. So here in Victoria, it's the Victorian DHHS, but every state and territory has an immunisation section that has lots of resources available on their page. Then this is the National Immunisation Program schedule. This schedule comes in the front of the book, and it's for the whole of Australia. So what you need to be very careful about is what state and territory you work in, because we do have different programs in different states. So the northern states, so Far North Queensland, NT, WA, and I think some of South Australia, they have extra programs and extra vaccines. So they have hepatitis A for their Aboriginal Torres Strait Islander children, which we actually don't give here in Victoria, Tasmania or New South Wales. So you need to be very careful when you're looking at this. They've just changed the rotavirus vaccine. So we used to have some states that gave Rotatec, and Victoria was one of those, and some states that gave Rotarix. As of July last year, now every state gives Rotarix. But if you've got an old schedule, you'll still get reference to Rotatec on there. And the big thing about Rotatec was that it was a 3-dose schedule, not a 2-dose schedule. So you have to be very careful when you're reading these schedules that you're reading for your state and you know which vaccine that you're looking at. So the Australian government provides funding for all of these vaccines, and then each state and territory can add different programs, and we'll talk about that just a little bit later. The Commonwealth Government also provides the funding for the Australian Immunisation Register. So when the register first started, it was known as ACER, which was the Australian Childhood Immunisation Register, and that's now moved to a whole of life register. And then we also have the National HPV Register for the Gardasil. So I think we get to talk about all of those just a bit later on. Oh, very next slide. Okay, there we go. So here's the Australian Immunisation Register. So ACER is the childhood register, started back in 1996, and it was a database to capture all of these vaccines nationally. And I think we were the first country in the world to actually have this register. And it is just such a bonus, because you don't think you're ever going to forget what your child's had, but I can tell you, by the time they get to school, you can't remember if they've had everything that they needed to have. So the register records all of the vaccines. And then as of 2016, as we introduced Zostavax, it became a whole of life register, which is such a bonus now, because especially with the over 65s, do they remember if they had their Pneumovax or not? No idea. You know, they've moved practices, they've moved into residential care. This way, with the immunisation register now, you'll be able to look up when they've had their last vaccines. The register takes all vaccines, so all children born after 1996 will have all of their immunisations on this register. The adults obviously won't, and we're not uploading histories, but as you give an adult a vaccine, then we are putting it on the register. We're just not doing a history for adults. Certainly we are for children. So children that come from overseas, you can actually upload an immunisation history onto the register to show all of the vaccines that they've had. You can also put travel vaccines on there as well. So any vaccine that anybody has can be put onto the register, which is really very handy. You know, they've had one hepatitis A, do they need another one? You know, have they had Japanese encephalitis? All of those sorts of things can still actually be put onto the register, which is really great. And the register actually talks to My Health Record. So that's another bonus for that. It's certainly up to the vaccine providers to make sure that the information gets on there in a timely manner. I'm just wondering if I get to, I do talk about no jab, no pay later on, so we'll talk about why it's so important. And yes, for a lot of you, your practice software will automatically upload to the register. What is really important is that people choose the correct vaccine to upload to the register so that they've actually given the right thing. So Infinrix might come up as the very first vaccine on the drop-down list, but you've actually given Infinrix Hexa. If you just tick Infinrix, then that child is actually going to be overdue for their vaccines because they won't have had all of the components that they're due for. And it's a big problem when it comes to enrolling into childcare or having their payment. So really, when you're entering your vaccines into your clinical software, it's really important that you're selecting the right vaccine, not just the first one that comes up. And they're laughing at me in the background. Okay, so Zostavax. So Zostavax was brought onto the schedule in 2016, and it's provided free for all people over the age of 70 with a 5-year catch-up program for people 71 to 79. So really important. So Zostavax is your herpes zoster vaccine, and we're trying to stop people getting shingles. It's a whole talk in itself, but it's really important that we do document when they've had their Zostavax vaccine. Giving the Zostavax vaccine, you don't have to worry about whether they've previously had chickenpox or not, because most people of this age group, they've done serology back a few years ago, and 97% of people in this age group will have had chickenpox in their life. So therefore they are able to get herpes zoster, get shingles, so we give the Zostavax vaccine. Having said that, you need to be very, very careful when you are giving the Zostavax vaccine that you have done your pre-screening checklist with them and that they do not have any immunocompromising conditions. So I think, okay. The other register that we have is the National HPV Register. For general practice, if you've got a child that's coming in, so most of our Gardasil is actually given through the school program. In year 7, as of this year, it's the new Gardasil 9, so it's a 2-dose only vaccine for children under the age of 15. If they're over 15, commencing their course for the first time, then it is a 3-dose vaccine. But for the majority of children, it's a 2-dose vaccine, and that's reported to the National HPV Register. If you are mopping up in general practice, or you've got someone coming into general practice because they don't want to have it at school, you can report that to ASA as well, but we are asking that you report it to the HPV Register because there's a bit of a lag between ASA and the HPV Register. So if you're only going to report to one, we'd actually like you to report it to the register. The register will give all the information to ASA. So really important that we know, and this is going to make a big difference now with this new vaccine only having 2 doses. We need to know who's had the vaccine, who hasn't. The schools will do it separately, so it's a bit hard to know if they've had it at school. I mean, all you can do if you've got an adolescent come in is actually ask them if they've had the Gardasil vaccine at school. Yeah. So that's a really good idea. So if you're unsure or the child's unsure, yeah, I had an injection at school, I don't know what it is, you can just ring the local government area where that school is, not where they live, where the actual school is, and they will tell them whether they've had it or not. Excuse me. We're not even going to go to what it was going to be called and what it's not. Okay, no jab, no pay. So this caused a lot of controversy when it first came in. So in 2016, legislation came in to say that people would no longer be eligible for their childcare benefit, their childcare rebate or family tax benefit Part A if their child was not up to date with their immunisations. And that goes from 0 to 19 years. So we've always been pretty good at recording childhood immunisations, but all of a sudden we had this whole group of children that maybe weren't up to date and the parents didn't realise they weren't up to date when they were 18. So to support this legislation, we now offer free immunisation to any child under the age of 19. So any child that comes in, any child that is under 19 will get free immunisation. You have an 18-year-old, and it's actually becoming more and more apparent, an 18-year-old first-year uni student whose parents haven't vaccinated them and all of a sudden they want to do nursing or medicine. They have to be up to date with their immunisations for clinical placements. They get free vaccination now. So any child under the age of 19. They need to be on a well, obviously if someone comes in for part of either the childcare benefit or the family tax A, you can't get them up to date immediately because you've got to have certain intervals between your vaccines. So as long as they are on a recognised catch-up program that has been registered with AIR, so they've had every vaccine that's due on the day, then the parents can keep up with the benefits. And I'm sure if you've worked in general practice, you've probably had parents come waving a letter in saying, they're going to cut off my childcare benefits if I don't get this vaccine, can you do it now? And you know, the cut-off is the next day. You just have to say that all I can do is send it up to AIR and Centrelink talk to each other, but it may not make it. So we're really trying to encourage the parents to come in on time, but they do get warning letters to say that they are going to have their benefits cut off if their child's not up to date with their immunisations. We no longer have a conscientious objection form. So back in the olden days, 2 years ago, people could object to immunisation. They can no longer do, they can object, but there is no form that they can fill in. And so if you consciously object to immunisation, don't want to have your child vaccinated, absolutely perfectly within your right to do that, but you will not receive any of these benefits. And in a number of states, Victoria being one of them, with no jab, no play, you will not be able to enrol them into childcare or into kindergarten. So really important that people are up to date and in a timely manner. Just while we're talking about no jab, no play in Victoria, just very quickly, GPs can no longer write letters of saying they're up to date. The only way that they can be seen as being up to date is through their immunisation history statement. And we'll talk about that a little bit further on. So I think we've covered everything. So free catch-up for anybody under the age of 19, and then also for all refugees and humanitarian entrants, there is also free catch-up for those people. And then there's various state-funded programs that we will talk about further down the track. Then we get to cold chain management. Okay, so this is, we do a lot of work to get people to come in to have the immunisations. You know, we talk to parents about their fears, we tell them why we're doing it. There's no point in going through all of this really hard work if the vaccines we give aren't viable. So what we're looking for is managing the vaccines, keeping them at between 2 and 8 degrees. So the Bible for this is the Strive for 5. So that 2 to 8 degrees, what you have to remember is when you're sort of thinking, oh, it doesn't really matter, this is from the point of manufacturer right through to this vaccination actually going into their arms. If you look at most of our vaccines in our fridges, they are not manufactured in Australia. So your infant Rixes, anything ending in Rix is actually a vaccine that is manufactured over in Rix in Belgium. So it's come a long way. So there is the potential for there to have been, you know, a couple of little breaches along the way. So really important that we are trying to manage our vaccines and we're giving potent vaccines to our children. So the way we manage cold chain, and it's not just cold chain, it's really the whole of vaccine management, I like to call it, is that you have one person in your practice or in your organisation that is actually responsible for it, making sure that the policies and procedures are up to date and that all the staff have been trained in cold chain procedures. The person that is responsible for it doesn't have to do everything. We find that in general practice, a lot of nurses don't work full time, but you've probably got a receptionist that works 5 days a week. So there is no reason that you as the nurse cannot train the receptionist up to read the temperatures on the vaccine fridge and record them and then tell you if there is a problem. So as long as they know what they're looking for, so if it's between 2 and 8 degrees, they know how to reset the thermometer, that's all fine. What we don't want to see, and has happened in the past, is people recording -3 or 16 and actually not doing anything about it. So just important that all the staff know what they're doing. We record the refrigerator temperatures twice daily, so as the practice opens, as the practice closes, or the organisation opens and closes, because it makes a really big difference about whether, if you do have a cold chain breach, whether those vaccines could maybe be used with a shortened expiry date on them. So rather than throw out millions of dollars worth of vaccines, which is what it comes to if you add up all the cold chain breaches across Australia, if we can actually save those vaccines. So if we know that within the last 12, it's only for 12 hours, not 24 hours, it may make a really big difference. We also need to make sure that we're looking at expiry dates on the vaccines to make sure that we've got the most current expiry date, or the nearest expiry date at the front and the other ones at the back, because you know when you go to the supermarket and you always reach to the back to get the milk that's got the longest expiry date on it. We want to use the ones with the shortest expiry date first. And then you need to, if you've got a data logger, and most people with purpose-built fridges, even if you haven't got a purpose-built fridge, you've got a data logger, we recommend that you download that at least weekly, and especially if you've had a cold chain breach, download it straight away to see if on the min-max thermometer it's saying a breach, download your data logger. It is not enough to have a data logger in your fridge and not record the temperatures twice a day unless you are prepared to download the data logger twice a day. Because if you're using your data logger and only downloading it weekly, not recording your fridge temperatures, you might download it on a Friday and have had a cold chain breach on the Monday, not realise that, and vaccinated all those people from Monday to Friday without actually knowing it and given them compromised vaccines. So if you have a data logger that you want to use instead of a min-max thermometer, you must download it twice a day. It's absolutely up to you. We also need to know what to do for a cold chain breach, who to report it to. So in most other states, it's to the local public health unit. Here in Victoria, it's to the Department of Health and Human Services. There's a great video around of Ewan McGregor doing vaccine deliveries. Oh, we tried to get him to come out for a conference, but he couldn't make it. He was really nice about it, except I think he probably knew how many people were fighting to go and pick him up from the airport and actually show him around. But he's done a great video. Just the lengths that they go to places like, Pakistan or Nepal or whatever, to actually maintain that cold chain to get those vaccines, 8-hour treks up mountains and things like that. So it's really worth having a look at. That was very nice. And then the Strive for 5 is also available from the Immunise Australia website, and it comes with a whole lot of other things such as temperature charts, stickers for your fridge, and I'll show all of those to you later on so as I'm not moving constantly for the filming. Okay, so what do we need to do? If there has been a cold chain breach, then so the temperatures are outside 2 to 8 degrees, the first thing you actually need to do is isolate the vaccines and not use them. You don't want to immunise someone with compromised vaccines. And I know some people that have actually gone to the extent of getting duct tape round the fridge so nobody could open that fridge while they were investigating the cause of the cold chain. Keep your vaccines in the fridge at 2 to 8 degrees, because if you've addressed the problem of the cold chain, and then contact your relevant state or territory health department. Here in Victoria, we have a slightly different cold chain protocol, and I will discuss that later on. Do not just go in and throw out all your vaccines. As I said, depending on what the temperature readings are and for how long, the good chances are that there's a number of vaccines that will still be viable. So please don't just throw them all out. privately purchased vaccines, so if you keep private purchased vaccines in the same refrigerator, you won't be able to get advice from your local health department. You will need to speak to the manufacturer about whether those vaccines are viable or not. Have I gone there? So there's no point in just ringing up saying, oh my God, we've had a cold chain breach, because the health department is going to want to know a whole lot of things. So they're going to know how long the breach was for. So this is where your data logger comes in really handy, because the min-max thermometers are often a lot more sensitive than the data loggers. Your data loggers often only read every 15 minutes. Your min-max thermometer might read every 5 seconds. So you can download your data logger, have a look, and it will tell you exactly how long your breach has been for and what the temperatures were. Your state health department's going to want to know that. Then they're going to want to know what you've actually got in your fridge. So how many vaccines you've got in there and what they are. And then if you've come in and noticed the breach, and this has happened on a number of occasions where maybe the nurse wasn't working on the Monday, say, she's come in on the Tuesday, realised there's been a cold chain breach, but it actually occurred on Saturday. She's been able to determine that. Then you're going to have to actually download all the have a look in your records to see who has been vaccinated in that time that may have received compromised vaccine, because you're probably going to have to recall those patients and have them re-immunised. You don't want someone to think that they're actually protected against a disease when they've been given compromised vaccine. So all of this is in Strive for 5. They've got everything that you could possibly want to know. And as I said, in Victoria, you need to look at the Victorian specific protocol. Okay, how to pack a cooler. So do any of you do off-site vaccinations, go into nursing homes to do them, go into workplaces? Some practices, also have corporate contracts and they'll go down to the local workplace or go into an aged care facility and take their own vaccines. And all of this is how to pack a cooler. This is very much in the Strive for 5, so I probably am not going to go in it. The really important thing about packing a cooler is to make sure that you don't stick the vaccines straight on top of your ice bricks, because you're just going to freeze the vaccine then. So you need to have things in between. You need to condition your ice packs, and that means taking them out of the fridge a little bit early. All of that is in Strive for 5, so I think that you can probably use it. If you are going to do off-site vaccinations, then it's really important that you have a min-max thermometer. So local governments will take vaccines off-site. You're always monitoring your vaccines. You can also use this cooler technique if you have a power outage. So if you've got a glass-fronted refrigerator, they actually lose the temperature really, really, really quickly, like within half an hour. So if you've got a power outage, it may be worth, as soon as the power outage is happening, if you happen to be at work, is start prepping for putting your vaccines into a cooler if you can. Not everybody has this, has their eskies just sitting around waiting for this, but some practices do. And in areas where you do get a lot of power outages, and that January is storm time, that maybe it is worth investing in having a decent esky that you can actually put your vaccines in. So this is all just more pretty pictures out of Strive for 5 on how to pack your coolers. But as I said, just making sure that you don't ever have your vaccine boxes sitting right on top of your ice bricks. Your vaccine fridge, so your PBVF. So if you ever see that, it's your purpose-built vaccine fridge. It took me quite a while to work out what they were talking about there. So yes, so we no longer recommend that you use domestic refrigerators. The whole of Strive for 5 is geared towards people using a purpose-built refrigerator, but there is an appendices that talks about how to run a domestic refrigerator as a vaccine fridge, but it's quite a lot of work to be able to do that. So what you actually want is a vaccine fridge that is a purpose-built fridge. There are some cheaper versions on the market that are just drinks fridges that have actually been converted and called vaccine fridges. It's worth going to a reputable company if you want a vaccine fridge. People will often say we can't afford a vaccine fridge, and it's because they've come out of a hospital situation and they think that a vaccine fridge is one of those sort of wall to ceiling, great big glass doors that they have in their hospital pharmacies. You can actually get a purpose-built fridge that is the same size as a bar fridge. So if you're only ever doing over 65 flus and you don't need a whole lot of vaccines, you can get smaller fridges. So don't think that they're all these enormous glass-fronted fridges. You can get much smaller ones. You can also get vaccine fridges that are not glass-fronted, so you can get purpose-built fridges that have actually got a solid door on them as well. We suggest that you put your vaccines in baskets, and some people like to put them via age groups, some people like to have the actual vaccine. So if you're doing a basket of, these are the vaccines we give at 2, 4, 6 months, you're going to have your Influenza, Hexae, your pneumococcal and your Rotarix in there. You need to have a really big sign about the Rotarix saying check the date of birth before giving this, because if you have a basket that just says this is the vaccine you give at 2, 4, 6 months, the child comes in, they're 7 months old, they've never been vaccinated, somebody says, oh, well, we need to give the 2-month vaccines, they may give them rotavirus and they're actually going to be too old to have that. So really important that people understand that you're checking all of these things. We're going to have a really, really good basket system this year too for all the different influenza vaccines that we've got. So really important that you look at things like if you've got a Fluria quad in your fridge, over 18s only. It cannot be given to children. So you need to make sure you've got that in a separate basket. Keep your paediatric vaccines well away from your adult vaccines. So as people know, I can't touch down there, you know, the red basket's adults, the blue basket's kids, something like that. Have some sort of system that people know that they can't use those vaccines in every age group, because people just tend to think, and we all just talk about flu vaccine. Let's just have a flu vaccine. There are so many different brands of influenza vaccine. You've got to be very careful that you're giving the right one to the right child. So getting back to actual purpose-built fridges, most of them have alarms, so if the door's left open, that's a really common preventable cold chain breach, is that the door's left open. So somebody's gone in and they haven't closed the door properly and then the alarm's going off. We actually had a practice where the nurse came in, she'd been doing over 75 health assessments. She came in, as soon as she walked in the front door, she goes, the fridge alarm's going off. How long has that been going off for? And everyone went, oh, is that what that is? We wondered what that noise was. So this is why we talk about everybody needs to have training and know what happens. So somebody could have done something about that, but no, 4 hours of the alarm going off and nobody actually knowing what to do about it. Every time you go and get a vaccine out of the fridge, you should be looking at the min-max thermometer display to make sure that it is in thing. We know that when you open the doors and you're putting vaccines away, the fridge temperature is going to go up a little while. If it's under 15 minutes, under 12 degrees, you know, once it gets up close to that 12 degrees, just shut the door, let the fridge temperature settle down again, and away you go again. The purpose-built fridges are fantastic because you can use nearly all of the space. If you're using a domestic refrigerator, there's a number of areas that you can't use. So it really is worth getting a purpose-built refrigerator. And they don't fluctuate as much as the domestic refrigerators. Having said that, we all know that the fridges are going to be really full at the moment. You know, flu vaccines are about to come in, so you're going to have fairly full fridges. Over summer, you might have sort of big empty spaces in your fridges. We still recommend that you put bottles of water or something in so you don't have a whole lot of dead space in there. It just helps making sure that that temperature doesn't fluctuate as much. And just try not to get them against the back wall. Some of them have their sort of cold plates there. You need to know your own fridge, and it's really worth finding out who your service technician is, talk to them or talk to the company that you bought it from, especially if you've come in, because often the fridge is there and then you've come into the practice and you've got no idea. Find out the brand and talk to the people about it, you know. Are there any spots I should be worried about? Is there anything I should be doing? How often should I be getting it serviced? They are like any other piece of equipment. They will not run forever without a service. And usually the first time you realise that haven't been serviced for 10 years is when you have a cold chain breach. And then you go, oh, okay. So really important that you know that and have that in your policy and procedure manual. The name of the service technician, when it was last done, when it should be done again. Okay. I'm just looking at the time, sorry, I just need to know where I'm up to. Pre-vaccination screening, really, really important. And as I said, Zostavax is the big example of this. We really need to know that the person is well on the day, but also that they're not immunocompromised. And so that makes a big difference for your live vaccines. So what we need to know is there's a pre-vaccination screening checklist out of the handbook, and most states and territories have their own one that you can download from the website as well. Or you have your own checklist. There is no reason that you cannot get your receptionist to hand out the checklist while they're waiting to see you. So mum and dad could be reading that, and then you can just go through it really quickly with them when they come in. Just saves a little bit of time, and they can say, oh, I didn't realise, the baby's been really unwell with quite a high temperature. They're more likely actually to have come in to see the doctor than have the vaccine, but yes, whatever. Make sure that the child is well on the day. If they've got a bit of a sniffle, that's fine. It's only if they've got a temperature over 38.5 that we're going to stop the vaccine for that sort of illness. But we also need to know if you're giving live vaccines, there are other people in the house that are immunocompromised, all of those things, making sure that the child themselves hasn't got some sort of condition, or the person that's being vaccinated. And you have to think really hard with the oldies, really asking them about it. This is the problem with the Zostavax. This person had chronic myeloid, chronic CLL, can't remember which one it was, and they'd had the diagnosis 20 years previously and had been totally well and hadn't really thought that was an immunocompromising condition. So you need to think about this. Ask them, if it's a baby, how did they go the last time? So if it's not their first vaccine, so were they well after they had it? Were they a bit grizzly, a bit irritable? Just find out how mum went after that last vaccination. For your adults, as I said, we're talking about the health, age, lifestyle and occupation, the HALO, and I will talk a bit more about that. And it's really important that we're talking about informed consent. Just because they've turned up at your practice to have an immunisation does not mean that they have given informed consent, which hopefully leads us very nicely into talking about informed consent. Okay, so this is the same consent as for anything. So for it to be legal, it has to be, the person giving the consent has to have the legal capacity to do it. They have to have been given the risks and benefits. It's for the procedure that's happening. I mean, gone are the days where people, maybe of my vintage, were in the hospital and the surgeon or the anaesthetist would roll up 5 minutes before someone was being wheeled into theatre saying, sign here, you're just consenting to have this operation. And people are like, oh yes, okay. No idea. Half of them, if you spoke to them, they wouldn't even know, oh, I'm having an operation on my leg. For what? I don't know. The doctor said I had to have it. It just isn't good enough anymore. So we actually need to, and especially in this day and age, they all watch Law and Order and all of those things, all those American television shows. So, litigation is going to happen. So what we want is people to give consent. If they've got a concern, they need to be able to voice that concern. And just because somebody has actually turned up on the day to have an immunisation, if they are really concerned, we cannot coerce them into having that immunisation. You are better off saying, I understand you've got some concerns. Maybe we need to talk about this a bit more and you can come back and have the immunisation another day. If you coerce them, they may have that immunisation that day, but chances of you ever seeing them again, it's pretty minimal. If you can actually address their concerns, then they're more likely to come back and complete their vaccinations. So, as I said, just because they've turned up, I mean, ideally, we would like to immunise everybody just as they walked in the door, and you'd like to just do it because they're there, but we do have to spend some time with people. You need to get the consent before every vaccination because the consent they're giving at 2 months is very different to even 12 months. You're giving different vaccines, so you've got to talk about different risks and benefits. The consent doesn't have to be signed on the dotted line here. You can just document, especially in this day and age where a lot of people are going away from having paper-based practices. It's all online. You just can document who gave the consent and that consent was obtained. That's fine. You don't have to get them to sign on the dotted line because it's actually not particularly valid. We need to be really careful with people that are coming from a non-English speaking background that they actually understand what we're talking about. There is a lot of translated material available, and so we need to make sure that they do understand it. Some of the areas actually have talking books where you can actually have the information spoken, because not everybody will be able to read, and not just people from other countries, even there are some Australians that can't read as well. So you have to make sure that people do understand and you're not just throwing pieces of paper at them. So you actually need to talk to your patients. Some people find that difficult. And documentation, yes, I think we've covered all of that. Okay, how are we getting there? We were going to do a role play, but given the time, we might leave role plays till the end, and then if we've got time, we can do some role plays. It does help though if you've not spoken to someone about doing a vaccination and they've got a few concerns, to actually do a bit of a role play, get someone that is a little bit more experienced to throw some of those curly questions at you, and then find out what would you say. And you get a spiel going after a while of, I need to say this, I need to say that. So we will do that. Documentation. Okay, so you need to document in the right spot in your clinical software, and if you're still paper-based, there's lots of things that you still need to do. So we need to know when the vaccination was given, the fact that there was a discussion. What I say is, if you actually have a policy and procedure, this is how we immunise in this practice. We always discuss this. We always give people this piece of paper, this pre-vaccination. We always give them this risks and side effects thing. Then you can say, as per the practice policy, discussion taken place, consent obtained by these vaccines given. So we need to know who the consent was from, because every so often you'll get someone come in and you say, "Are you mum?" And they say, "No." "Who are you?" "I'm the nanny." Well, I actually need consent from the mother. You can ring the mother up and make sure, but a nanny cannot consent for that child to have the vaccination. It has to be from the parent or legal guardian. Who's actually given the vaccine? So if there is a bit of an adverse event or something like that, we know actually who's given the vaccine. We need to make sure that the parents understand when to seek medical advice. So if you've done a proper risks and benefits, so your child is likely to get a bit of a fever, could be a bit grumpy, this is what you need to do, that's fine. But you need to also, so they expect that, but you need to be able to say to them, if your child is really unwell, screaming, drawing up their legs after they've had rotavirus vaccine, we want you to get medical assistance straight away because this could possibly be interception. So you need to discuss those things. So just discuss these things and document that you've discussed the risks and benefits. They must wait for 15 minutes afterwards. I say you don't actually have to sign that off. Have that as part of your policy. You don't have to see them. If you've got a policy that they wait in the waiting area, playing with the toys, because that's what they're doing, making their next appointment with the receptionist, they can just go after 15 minutes saying, "Everything's fine, I'm happy to go." And they can tell the receptionist that because that's your policy. If there is any doubt, if the mum's concerned in the slightest bit, yes, of course, then you need to review them, or the doctor needs to review them. You need to make sure that they understand when they need to come back for their next vaccination. You might as well take advantage of this 15 minutes and actually get them to physically book the appointment with the receptionist to say, "All right, we need to see you again in 2 months' time, go and make an appointment," or "We need to see you when the child's 12 months, go and make an appointment." We'll SMS remind you, hopefully, just so you don't forget, because if you don't get an SMS reminder, you never remember to come to anything, if you're like me. And then just making sure that it's been reported to the relevant register. So if your software uploads it automatically, that's fine. If it doesn't and you need to manually upload it to the ACER website, then to the AIR website, that you've done that. Okay, safe administration of vaccines. Now I have to keep remembering that I'm not doing the nurse immuniser course where you're allowed to do everything by yourself. So, and I just did a study day yesterday, so excuse me if I sort of move over into things. All right, so as we've already said, vaccines are S4 drugs. So best practice is, if you've got a second person to check it with, hopefully you've got another nurse, but you may need to just check with the GP. I always think it's a really good thing too, because it actually means that you can do a bit of education when you're double checking with someone that maybe isn't giving immunisations all the time. Never be afraid to say, "I actually don't think you've realised that the schedule has changed and this is not the right medication, the right vaccine for this child at this time." Or they think because the child is 12 months that they just need to have the 12-month vaccines, when you've actually worked out that they actually haven't had their 6-month vaccine. So there's other vaccines that need to be given. So just to make sure that everything's safe, as I've already said, just check the fridge as you go and take it out. Any time I walked into the treatment room, I would just be looking at the fridge temperature. They didn't call me the ice queen for nothing. So yes, I'm a bit paranoid about it because I've had to sort of deal with a lot of cold chain breaches. The other thing is that most vaccines actually need to be reconstituted, and we have that on the schedule. So really important, if you don't reconstitute the Immunisation hexa with the Hib pellet, those children have not had Hib. And we've had that where we've had cold chain breaches, you've gone in and you've found one vaccine left in the Immunisation hexa 10 box and 9 pellets. So then you don't know, you've got to recall every child that's had that Immunisation hexa to actually then give them Hib, don't have monovalent Hib anymore. So really important to make sure that you are using the pellet that is provided. So if something goes wrong and you drop it, don't just think you can go and get some normal saline or water for injection to actually reconstitute, because it's actually part of the vaccine, maybe one of the antigens. Every so often, we've got nearly every vaccine in our fridge, well, up until recently, had a RIX at the end of it. So you've got to be really careful that you are giving the right Immunisation hexa, Immunisation IPV. You've got prior RIX, you've got prior RIX tetra. You need to be really careful that you are giving the right vaccine. You also need to be really careful with dates, because if you give the vaccines too early, you never need to restart a course, but if you give the vaccines too close together, you're probably not going to get the antibody response you want, but they are going to be considered invalid doses. So making sure that you've got the right timing between your vaccines, and most vaccines you need at least 4 weeks, but things like Hib, because we've got, Hep B, because we've got such a wonderful schedule with that, you may need to leave 8 weeks, you may need to leave 3 months. You've got to make sure that you have got the right timings there. You need to make sure you've got the right person that you're going to give the vaccine to as well. Got a family of 6 coming in and they all need to be vaccinated. Make sure you're giving the right vaccine to the right person. And just everything is documented. And I really strongly suggest that you have a bit of a policy. This is what we've done in the past, and it's really helped, is that the policy is, and you don't have to do it, but like we always give, Immunisation hexa always goes into the right arm. Pneumococcal always goes into the left leg, whatever, that sort of policy. And then it means if you're not on and the child comes back with this huge reaction, we know that it was Immunisation hexa that they've had in that arm or their leg or however old they are. And that we're actually giving the vaccines in the right spot. So under 12 months, we're always going to use the anterior or lateral thigh. Over 12 months, we're going to use the arms. If you're unsure about this, it's in the handbook. There's great pictures of where to give these vaccines and how the child can be held. Because believe me, they are not going to lie there while you jab them doing nothing. Okay? Okay, so we need to make sure, as I said, we're doing the right person, the right medication. So we've got the right vaccine and it's the right dose, the right route, as we've just talked about, at the right time. We've got the right intervals there. You've got the right documentation, the right reason. We're giving the 12-month vaccines because they're 12 months, or we're giving the 18-month vaccines at 4 because they haven't had them. We're the right reason there. And we're getting the right response. And I had this really good example to give you, and I can't remember what it was. Oh, I know what it was. So the right response. So if you've given an adult their course of Hep B, that you've told them that they need to come back and have their bloods done to check their serology. Never going to do that for children, because we just presume that they will get the response. So that's the response that we need. Really important then, when we're giving these vaccines, that you're using the right needle as well. So if you've got an 18-month-old that you're giving an IM injection to, not a subcut. A lot of our live vaccines are subcut injections, that you're not using a little tiny 25 gauge needle that's little, because you're not actually going to be giving that injection as an IM injection. You need to use the right needle for the size of the child, and sometimes it means that you actually have to look and think, this skinny little chicken arm is not going to take a big 23 gauge needle, or this big boisterous baby actually does need that. I can't use a 25 gauge needle unless I'm doing a subcut. You're not doing them any favours because you're going to get a much better response if you actually give a proper IM injection. So I think we've done that one. Oh, I keep turning the thing around the wrong way. Oh. So let's talk about having to hold a baby. So for a lot of you, this is going to be something quite different because you're needing the parents to hold the child for you. So depending on the age of the child and how you're comfortable and how the parents are comfortable is how you're going to hold the child. For a baby under the age of 12 months, it's often mum holds the baby, cradling the baby, nursing the baby. You need to make sure that mum has got a good grip on the arms. You as the nurse can control the leg, give the first injection, then mum needs to swap the baby over, same thing, holding the arm, you've got control of the leg. Alternatively, you can have the mum, especially if there's two of you available to vaccinate, have mum with the baby on her lap facing you. So mum has a grip around the baby's top half, holding the arms down, and then you have a nurse either side and you can administer those injections at the same time. If you are going to have two people administering injections, then you need to make sure that you're also looking out for your OC health and safety, that you're not both going to be going for a sharp spin at the same time. So do be wary of that. You can also use that technique for 12 months or 18 months, knowing of course the older they get, the more uncooperative they are going to be. So either way, so sometimes for the 4-year-olds you can have mum cuddling the child so the child's actually facing into mum. You've got the legs either in between her legs or out there, just being very careful. And then you're controlling the arm. Mum's got a really good grip on the arms and you can give the injection that way. Alternatively, you can have the baby or the child sitting on mum's leg, and we do what we call the over-under technique, where you've got mum going over and under holding the arms that way in a good grip, because you want to make sure that that child isn't going to suddenly jerk out and you've lost the immunisation. The other thing is that a lot of the pre-filled syringes now come with a little tiny air bubble in it. Leave it. Do not exfoliate. Don't do those big things. You know in the movies where they have these great big things with horse needles on them and they're always injecting the vaccine into the air. Don't do it. Don't prime your needle. Okay? So just give it as it is done. Post-vaccination procedures. So we need people to wait for 15 minutes after vaccination in case of anaphylaxis. We've had an incident where there's been an elderly gentleman who actually had a vasovagal 25 minutes after having a vaccination driving home. So it's tell your older patients to be very careful driving, operating heavy machinery, things like that, because you never know when they're going to have a vasovagal. And as I said previously, you've got that 15 minutes to make the next lot of appointments, talk to them about the rest of the family's vaccination status, whatever. So, and provide that written information on common reactions, and we'll have a look at that. So, which just segues very nicely into adverse events following immunisation. So we do expect that most people will get some form of either a bit of a temperature, sore arm, you know, think about the last time you had an influenza injection, you know, as part of your workplace, hopefully, you know, you get a bit of a tender arm. And so we need to tell people to expect that. You know, for babies, they're going to be a little bit irritable, crying, you know, and give mum the advice of what they need to do for that. So, you know, just comfort feed them a bit more often, make sure they're not too warmly wrapped up, because people tend to swaddle them up, you know, trying to comfort them and they're actually a bit hot. Give them some extra fluids, give them a bit of a cool bath. If you really have to, if they're really irritable, try giving them a dose of Panadol, not the first line for your normal NIP vaccines to give Panadol. If they are going to give Panadol, make sure that they understand that there is a baby Panadol. Just because you've suddenly had a baby doesn't mean that you suddenly know all of these things. And so we've had instances where parents have come in saying, how do you give Panadol? Do you crush up the tablet and put it in the, you know, in their milk, or what do you do? So let people know that there is infant formula Panadol that they can get and how to give that. We need to just make sure that they understand that, you know, for some of the vaccines, so some of the live vaccines, there's a possibility of them getting rashes. So if we give them all this information, because you're going to be talking at them for quite a while, and they're not going to retain all of this information because they're really worried because you've got this precious little thing of theirs and you're going to stick a needle in it. So make sure they do have the written information so they can get home and say, oh, that's right, they did say that the baby might get a rash after 5 days or 10 days or whatever. That's all good. Adults, you might get a bit of a headache, or, that you might need to have a bit of a sore arm, especially if you're giving something with tetanus in. The more tetanus injections you have, the more likely you are to have a local reaction. And that they can get this hard lump at the injection site is quite a worrying thing for parents, that if you've given this injection and then all of a sudden they can feel a lump and they're worried that you've given their child cancer or something like that. So if you let them know this is just a reaction to the injection going into the muscle, it's fine, it doesn't hurt them, they're all good, then when they see it, they can certainly get it checked out if they want to, but it is quite a common reaction. So nobody worries as much if they're expecting it. And in fact, you can do too good a job. I had a parent that came back and said, nothing happened. I don't think you gave the injection. They didn't have a temperature, all of this. So are you sure you gave the right thing? So yes, sometimes you can do too good a job. Okay. If there is an adverse event following an immunisation that's not one of the common ones, then we need to report that. And my feeling is that if a parent is worried enough to bring a child back in to say, I am really worried, then that event actually gets reported. It's not up to us as the immunisation providers to have to worry about causality, whatever. It just needs to be reported. If people had reported a bit earlier about their children having really, really high temperatures after the influenza vaccine over in Western Australia, if that had all been captured, then we mightn't have had the disasters that we've had in the past. So what we need to do is make sure that parents feel that they can report these things and we can report them, and then it's up to somebody else to decide if it's actually any causal link between the vaccines or not. We need to be really safe with vaccines. Here in Victoria, we report to SafeVic. Different states have different reporting mechanisms, so it's up to you to know where to report your vaccines. But as I said, here in Victoria, it's with SafeVic, and I think it actually comes up in the next slide where we actually report to. When you report to SafeVic and some of the other states, they then will report to TGA. So there's no need for you to report to TGA here in Victoria. SafeVic will do that on your behalf. So some common adverse events that we are getting is extensive limb swelling from the joint above to the joint below the injection site or beyond the joint. So it's a bit hard to see in that photo, but that is quite extensive swelling. And what we're seeing this either at 18 months or 4 years after one of the DTPA injections. It's usually totally painless, and the parents are only noticing it because they're bathing the child and the child's running around in that, they can swing from monkey bars with it. It's not thing. If you do get that, we do want it reported. So if you do have a child that comes back in with that, report it, and you can always take a photo of it too. Parents are really great at that now. They've got phones. Everything goes everywhere. So take a photo of it. It's really good if they've got a bit of a ruler that they can, just show how big it is compared to that, but it usually causes the child no pain whatsoever. Vasovagal, if people are going to faint, they often do it easily first off. If you're doing an adolescent and they've come into general practice because they don't want to have it done at school because they faint, lie them down before you give them their immunisation. What we're doing in the school programs, if they're known fainters, is they're lying down with their feet up for 5 minutes before you even give the injection. So they're lying down and they stay lying down, and then sit them up really slowly. Don't get them going up. Adolescents, before you give them an immunisation, ask them if they've had anything to eat or drink that day. They're really good at not doing that, especially in the school program. They go rushing off to school because they're running late. They haven't had anything to eat or drink. If they're a bit anxious anyway, they don't want to eat or drink because they're feeling really sick and whatever. So make sure that they have something to eat or drink as soon as you've given it. If they're anxious too within the school program, try and do them first. There is nothing worse than waiting and watching 20 other people walk through that door. You can't see what's happening. Just get them in, out, and if they're feel at all faint, make sure you've got them down on the floor, feet up. When do we need it reported? Certainly if there's exceptional pain, unrelieved by simple analgesia. What we say to people if they've got a sore arm, put a cold compress on it, cold face washer, give them a bit of Panadol. If that's not relieving the pain, then certainly they need to be seen. Persistent crying, we do really worry about intussusception in children after rotavirus vaccine. So if they can't be comforted, they look pale, they're drawing their legs up, they certainly need to be seen. Then the other thing that we have is the HHE, which is a hypertonic hyper-responsive episode, which is a very scary thing for parents. So the infant typically can even be in the mother's arms and they go pale, floppy, unresponsive, lips might be a little bit blue, and people think their baby has died. They just will spontaneously resolve, usually after only a minute or two. The parents will tell you they've shaken the baby, they've even might have started mouth-to-mouth resuscitation on it, and the baby comes back, and by the time they actually bring the child in to see you at the surgery or into the hospital, they've usually called an ambulance. You've got this happy bouncy baby sitting up there. Sometimes they're not, they're still a bit unresponsive, but it's a very, very scary thing for parents. For things like that, they need to be reported and they need to have their next immunisation done, usually under supervision. You don't want to be doing that one out in the community again. If it's very unlikely for them to have a second HHE, but they can have a second one. So it's really important that the parents feel quite safe in having this vaccine, their child vaccinated again, and it is an awful thing to see. And I mean, I've had it happen, can happen up to, I think it's 48 hours afterwards. I've had it happen fairly soon after giving an immunisation. I'm sitting there going, oh my God, this child's arrested, you know, but they haven't. It was just, you know, all of a sudden they're just like, no, they're still breathing, they've got a pulse. So where the mechanism is unknown, it's almost as though it's a baby faint. Like, you know, they don't faint as babies, but maybe this is the same sort of vasovagal response. It's not particularly known. And then, as I said, we've talked about vasovagal. So anaphylaxis. So this is a really big thing, is we don't want anyone to have an anaphylaxis afterwards. I always ask, has anybody had one in the room, because it's about 1 in a million. I don't think I've probably given 1 million immunisations, but I also like to know that somebody else has had that, that's going to be their problem, that they've had an anaphylaxis. So it's the same as any other anaphylaxis. So it's potentially life-threatening. You know, they come up with the swelling, the urticaria. They can have gastrointestinal things. It's very unusual for it to happen the first time that they're exposed, so it's usually the second time that they're exposed to the allergen. And for an anaphylaxis, they usually say that it's 2 systems are involved. So if you've got someone that's got the hives coming up, I would be having the adrenaline there ready to go. And then you'll probably very soon see a second system involved, and then away you go. You're never going to kill someone by giving them adrenaline, even if it's not an anaphylaxis. You are going to kill someone if you just sit there waiting for it to maybe not, and then they've arrested. You're always much better off giving adrenaline and then worrying about it, because the earlier you give the adrenaline, the better they are when you're treating an anaphylaxis. As I said, it's the same for any anaphylaxis, and so vaccines are no different. Really hard in the stress of the moment too, and if you haven't looked after children, to try and find pulses and things, and you're never going to do sort of little radial pulses. You need to go for those strong sort of carotid or brachial pulses when you're looking for a pulse. Catch-ups. This is the bane of most nurses' lives, trying to work out catch-ups for people, because it's a really complex area. There's lots and lots of different rules and time frames. Luckily for us, we have this wonderful thing called the South Australian Catch-Up Calculator. I can't recommend it highly enough for people under the age of 10. It will not tell you the vaccines that the child is due, but it will tell you the antigens that the child is due. So at least then you can either work out the catch-up yourself and double check it against the South Australian calculator. Yes, I have got all of those antigens in there, or you can get the antigens and then work out what vaccines the child needs to have. No child will ever come into Australia up to date with the Australian NIP schedule. We give the most funded vaccines of anywhere in the world. So if you've got a child that has been born overseas coming into Australia, they will always need some sort of catch-up, be it Gardasil. You have to look at other countries, maybe such as the UK, where they do very different vaccine schedules. So they were giving meningococcal C at 2, 4, 6 months. Here in Australia, we recommend that they actually need to have one meningococcal C vaccine in the second year of life. So even though they've had 3 meningococcal C vaccines, we actually need to give them another meningococcal vaccine after 12 months for it to be considered a valid dose here in Australia. So there's lots and lots of different things in the handbook about this. I highly recommend, if you're trying to do catch-ups, all the catch-up tables are available, or all the tables from the handbook are available on the NCIA's website, just on one site, and I'll show you that in a few minutes. That's the easiest way of finding them. You have to know that you're looking at the right catch-up table for the right child. So if you're trying to catch up pneumococcal, are you looking at a child in far north Queensland that is Indigenous, or are you looking at a Caucasian child in Victoria? There's 2 different catch-up tables for that, and then you've got another catch-up table for children that are medically at risk. So you need to make sure that if you're trying to work out catch-up, that you are actually using the correct table. And then, as I said, migrants and refugees and people from other countries are probably going to need a new schedule. And you will find that some countries may not have given vaccines to our schedule. So here in Australia, we like to see that the Hep B, the 3rd dose of Hep B, has not been given before 16 weeks from overseas countries for it to be considered valid. And a lot of countries give a 6, 10 and 14 week schedule. So you need to not only look at what vaccines they've had, but when they've had them, as to whether they're up to date with their immunisations or not. You may need to give an extra dose of Hep B. A lot of countries give measles at 9 months. If they then haven't had 2 doses of MMR, that's not considered valid here in Australia. So there's lots and lots of different rules. I totally suggest that you find a friend that knows how to do this when you first start out trying to work out catch up. What the Department of Health suggests is that you try and do it all yourself through the South Australian catch-up calculator for the under 10 years of age, and then if you really have got nobody else to ask, then you can discuss it with them, but they'll want you to have had a really good go at trying to do it yourself before you ring them up. There's no point in ringing up saying, I've got this child that needs this and what do they need, because they're going to tell you to look it all up first. And I think that was the same in most of the states. I don't know, some states may run a catch-up service. We certainly don't. From the handbook. So in the handbook, there's different ones for different vaccines. You've got Hib, you've got pneumococcal, there's all different ones. Also from the handbook, it'll tell you what vaccines the child, so the number of vaccines they should have had by what age. So for under 10 and over 10 and what they need, and you can work from those. That's another whole talk in itself. Sorry. So we'll skip the role play. And now we're going to go to Halo. So this is the health, age, lifestyle and occupation for special groups. So what we would need to know when somebody comes in is, are they well or are they ill? Because that makes a big difference about what they need. Are they pregnant? Are they planning a pregnancy? Do they plan to, are they about to have an operation, or have they just had an operation? Have they had blood products? All of these things make a really big difference for people. Do they have HIV? What is this? I suggest if they've got HIV that you actually speak to their specialist before you actually vaccinate them. There are a number of vaccines that these patients can have, depending on their CD4 count, but I don't think as a nurse in general practice that you should be making that decision. I think that's a decision that the specialist makes. So in the consultation with the specialist and the GP, you can work out whether these people get things. If they've got a non-functioning spleen or they've just had a splenectomy, they need to have all of their vaccines again. If they've had chemotherapy, there's lots and lots of reasons that people may need to be revaccinated. Talking about spleen, here in Victoria, they can actually be part of the spleen registry, and that's a really good service that's run out of the Alfred Hospital, and they will talk to them about what vaccinations they need to have and how often they need to have them. So there's lots of things. We need to think as healthcare workers, what is our vaccination status as well. Then you need to look at the age. When are you going to have your vaccine? So we've got the NIP schedule. We don't seem to have the adolescent vaccines in there, but how old is someone? What should they have had by this age? Looking at the over 65s and now the 70-year-olds. If they're Aboriginal Torres Strait Islander, they may get their vaccines earlier, so they will get their influenza and their pneumococcal at 50 years of age, not 65. So you need to look at these age style things. So then we have lifestyle, so we have to think about, are they travelling? So what travel vaccines are they going to have? Everyone gets so caught up on their travel vaccines that they forget to actually have a look to see if they're up to date with their NIP vaccines. Have they had their pertussis? Have they had 2 doses of MMR? All of those things need to be looked at as well. Have they had Hep B? Are they travelling? Am I going to be giving them Hep A and Hep B? Give them Twinrix. All of those things. We need to look at, are they men who have sex with men? We've got a big program happening here in Victoria, and there are some other states where men who have sex with men will be eligible for some other vaccines. People who inject drugs, people who have got hepatitis B, their families may be eligible for new vaccines. All of this sort of stuff as part of your lifestyle you have to think about. Some of those vaccines will just be recommended, others will be funded. So that's up to you to know which ones are actually funded and which ones we're recommending to people. Going back to the age, we say that people that were born prior to 1966 have probably been exposed to measles. So we probably wouldn't give them a measles vaccine, but what about varicella? They may need a varicella vaccine, and if they're over the age of 14, they're going to need 2 varicella vaccines. So these are the sorts of things that you need to know. Occupational risk. As I said, healthcare workers, you've got to worry about what is your vaccination status. There's nothing worse than the healthcare worker being the person that's actually passing on the measles that's come into their practice, and it's happened in emergency departments and things like that, where somebody has come in with measles and it's actually the staff that have been the transmitters of the disease because they're not up to date with their vaccination. So you need to know, and for general practice it's part of your accreditation to know the staff vaccination status. What's your pertussis like? You've also got to look at other people's occupations, so people that come in, if they work in a piggery or they work in a chicken place, I don't know what they're called. You've got to think about their influenza vaccines for the worry of swine flu and avian flu. So all of those things you've got to think about. People working in the sex industry, you've got to think about those things. Don't be afraid to ask questions and tell people while you're doing it. All childcare workers should be up to date with their vaccinations, and it's probably something that they don't actually think about working with children, because we all know how good they are at, blowing their noses on you and coughing and spluttering. That was the occupational risk. So somebody within the practice should be responsible for the staff vaccines, and you should be getting annual influenza. I always sort of used to say to GPs, it's part of your occupational health and safety to have the annual influenza vaccine provided free of charge for your staff, because it means your staff are going to turn up to work because they're not going to have the influenza, and it's a much happier environment. What if people don't want to vaccinate? And we have touched on this, and more we are getting people. There's been a great study done by a person called Julie Leask, which you can find, just Google vaccine hesitancy and Julie Leask, and it talks about parents and their attitudes towards vaccination. And so you probably get, around 30% of people will just come in and get their children vaccinated because that's what you do. You get your children vaccinated and it's a good thing, and we know that we don't want our children to get sick. Then you've probably got, around another 30% of people that will turn up and have their children vaccinated, but they're actually really scared about it. Am I really doing the right thing? I've heard these stories, but yep, I'm just going to do it because I do want to protect my child. Then you can have these hesitant parents. Do I really want to get my child vaccinated? I'm scared about them getting the disease, but I'm also really scared about the side effects of this disease. So these are the people that you need to spend some time with. You need to spend time with everyone, but you need to hear their concerns and let them tell you what they're concerned about. I've read this article, so let's say to them, all right, you might have read that article, but have you seen this information? And there is a lot of resources out there for parents. You've got Understanding Childhood Immunisation. We've got a new set of fact sheets calling they're the SCAE fact sheets, so sharing knowledge about immunisation that addresses some of these concerns about vaccine side effects, about autism. Make sure that you've got access to these for the parents. We've got parents that say their immune system, and I don't know why, is suddenly fabulous at 2, and that's when I want them to have the vaccines. Okay, fine, but just understand the consequences of them not being vaccinated. You know, that they're going to be exposed to these diseases, you're going to risk losing your childcare benefits, you're risk in some states not being able to enrol your children in childcare. As long as they understand it, we cannot make it is not mandatory for them to have vaccines in Australia. And as I said, I would rather spend ages discussing it with parents and making sure that they then do get the full course than making them have a vaccine so they can get their child into childcare and then never see them again. Here in Victoria, we're really lucky that we have SafeVic, and so we have the immunisation clinic at the Children's Hospital and at Monash. And at the Children's Hospital, they can actually make an appointment to see a paediatrician and discuss their concerns. And sometimes that's just enough for parents to have that umbrella of the Children's Hospital to address their concerns. And then you've got parents that just say, no, I'm never going to do it. And these would have actually been conscientious objectors, or may even not even have registered as conscientious objectors because they object to being labelled as objectors because they just feel that they're doing the best thing that they can for their child. There are some resources for people like that. There's a fabulous campaign that's come out of Western Australia called I Immunise, and it's run by a researcher, Katie Atwell, who has looked, and her campaign is I co-sleep, maybe not my favourite thing, but I co-sleep, I only eat organic, and I immunise. And so just because you have an alternate lifestyle doesn't mean that you don't have to vaccinate. So it's worth trying to find some of these resources like that for people. You need to also keep the conversation open because you don't know what's going to happen to somebody within their family situation that may make them change their mind. So when somebody dies of cirrhosis of the liver because they've actually had hepatitis B, within the family they may decide they actually do want their child to be immunised against hepatitis B. So just keep the conversation open. I understand that you don't want to immunise at the moment, that's your choice, but if you ever change your mind, I am more than happy to see you again, because you want to know what's going on in their lives. So don't ever shut the door. It's very tempting to, but yeah, you want these people to keep coming back to your practice. And it also then gives you the opportunity, all right, so the child, they're happy to come back to the practice. Oh, I just wanted to see any change in attitude about the vaccinations. No, all right, well, we'll just discuss this today and we'll talk about vaccinations maybe the next time you come in if you want to. I think we've talked about that. And as I said, NCS has got some, like an MMR decision aid that the parents can get to. They'll often have done some Google research themselves. Just make sure that you're offering them the scientific, up-to-date sites, not the vaccination skeptic sites where a lot of that information there is not scientifically based. Goals for your practice. What are we doing here? We need to make sure that everything's evidence-based, that you've got a policy and procedure manual, that you know what you're doing and why you're doing it. So you've got, I say to people, I should be able to walk in as the agency nurse because you've won Tats Lotto, you've left, and I walk in and I can pick up your policy procedure manual and I can run the whole of your vaccine program because I know where the data logger is in your fridge and I know how to download it. I know how you order your vaccines. I know where the service technician is. I know that this is your policy for consent. This is the information that we give parents. I know that you only give you infomix in the left, whatever. All of that needs to be written down. And so one of the things that I say, especially if you've been working in a practice for a while, give the policy and procedure manual to the person that's the newest in the practice and say, try and be me for the day as the nominated vaccine person. and see what they can do, because often you write things down, but if you're anything like me, you miss out 3 steps in between because you just do it so automatically. So think about all of these things. Have bookmarks on your computer for the Immunisation Handbook, the South Australian Calculator, and the National Centre for Immunisation and Research Surveillance fact sheets. Here in Victoria, you can also have MVEC, which is the Melbourne Vaccine Education Centre. Have all of those things bookmarked so they're there in your favourites so you can go to them really easily. So what are our key messages? How am I going for time? Good. We need to do pre-vaccination screening. We need to take every opportunity of someone coming in to assess their immunisation status. So even if they haven't come in for an immunisation, talk to them about their immunisation status. Make sure that your practice software is up to date with their immunisations. We need to have a policy on how we obtain informed consent and get informed consent every time that we vaccinate. We need to provide catch-up where we can and phone a friend if you need someone to help you with it. And it's really, really important that we report to the immunisation register promptly, because it is going to make a difference for people's payments and enrolling into childcare. And then we also need to be able to report adverse events, know where we're going to report those adverse events, and be really confident about vaccine administration. I always say here in Victoria we're really lucky because you could always ring up your local government and go and say, could I just have a look at one of your sessions? How do you do this? How do you hold a child? Find somebody that can show you how to hold a child, how to talk to the parents. It's always really helpful if you can do that, even if it's not within your practice. If it's a friend, just see if you can go and see how they do that. That's why I always like, if you can just practice on dolls. How would you hold it? How would you get mum to hold it? Do those sorts of things with a friend. There's lots of useful websites that will be in in your notes. Take advantage of them. And then APNA also has ongoing learning, so there is an online learning module that you can do, and that's a really good thing to do. Just be really mindful that this will not accredit you as accredited nurse immuniser, but it gives you a really good basis for your immunisations. So that's what we're going to do for this part of it. Now I'd like to do sort of fairly Victoria specific immunisations. So I'm just going to pop out of this. This is why we do it, I just love, we want healthy, happy children. So here in Victoria, this is the Department of Health and Human Services website. If you just Google Immunisation Victoria, this will bring up the immunisation section website. They do a great newsletter that comes out once a month. I highly suggest, I can't suggest it strong enough actually, that you actually subscribe to that newsletter and make sure that it comes to your inbox, because it gives you all of the updates that are happening. So this is the March newsletter, so that it's telling you here in Victoria, well, it is happening nationally actually. This is a national program that at some stage this year, this is Victorian. The meningococcal ACYW will come on at 12 months. No, that is national. The meningococcal ACYW in year 10 is a state-based thing. So what the eligibility is, what's happening with Gardasil 9, they'll often give you links to things like the ATAGI advice. So you've got all of that there. Then when you move down, you can even get past things. The other thing that we have here in Victoria is the Vax on Time app. So parents can download this app, and that's going to give them the reminders of when their vaccines are due. So it's just another thing that helps them. In your practice, you might have your own recall and reminder system, but this is, the more times you get reminded about something, the more often you are going to do it. One of the other things that we used to do was, happy birthday, you've just turned 1 and you're due vaccines. Happy birthday, you've just turned 4, you're due vaccines. Happy birthday, you're 65, you need some vaccines. You can do, your recalls and reminders don't have to be come in. And you can do it these days, SMS. I mean, who doesn't have a mobile phone these days? So work out how you can do your SMS reminders. So then you have all of your resources. So it talks about special risk groups. Here's your immunisation schedule. I'm just probably not going to do it. So what we have now here in Victoria is we have beautiful colour-coded schedules. It tells you, does the vaccine need to be reconstituted, what antigens it's actually vaccinating against, and where to give it, how to give it. It's IM, it goes into the anterior lateral thigh. Then you have these colour-coded little yellow parts, which are, do they have a medical risk factor? In this case, then we actually need to give some extra vaccine. So at 12 months, was this baby prem? If this baby was prem, they may need an extra pneumococcal or an extra hep B. You need to know all of these sorts of things. Childhood is blue, adolescence is orange, adults, sorry, am I going too fast, Gary? Green, and then we have additional at-risk groups. And this is where we've got a lot of Victorian-funded programs for our at-risk groups at the moment. So I'm going to see what things. So they've got lots of things. Oh, the other thing that we haven't actually looked at is the cold chain management. So I haven't discussed that. So here in Victoria, we have, I don't know if you can see those. Sorry, I just keep moving. So there's a magnet that you can order from the Department of Health and Human Services to put on your fridge, and it tells you what to do in case of a cold chain breach. So when you need to notify the department and when you don't. In Victoria, we are different from every other state and territory in that if you have a cold chain breach of less than 6 hours, of less than 25 degrees, you do not need to report that to the Department of Health and Human Services. What you do need to do is mark all your boxes of vaccine to say cold chain breach, so just put CCB date. So if you do happen to have another cold chain breach, that you actually know that that vaccine has already been breached. Really important that you document it on your fridge, wherever you're documenting your temperatures, so people know that you've had a cold chain breach. If you then have a second breach, then you need to notify the Department of Health and Human Services. And within this thing, we've got all the forms and things that you need. So it tells you what to do for a cold chain breach. It has you have things on what to do for power outages. So if you're having power outages, it gives you lots of information. So it's certainly worth exploring that site and trying to see what they do have there, because it's lots of information. Then we have, sorry, I just need to. Then NCIS, which is the National Centre for Immunisation Research and Surveillance, has lots and lots of fact sheets. So the one that you probably would be the most helpful for general practice at the moment is the meningococcal disease, because it talks about the fact, it talks all about all of the meningococcal vaccines that we've got. So meningococcal ACYW, Bexsero, which is not on the schedule, but the meningococcal B that we should be recommending, meningococcal C, and whether you can give them. So they're sort of together or not, or how far apart we need to give them, which one should we give. All of that information is there, and it's for immunisation providers, and then they've also got a frequently asked questions fact sheet as well. So I highly recommend that you go through looking at these fact sheets, download them and just have them. I just have a book where I keep all of this stuff so I can get it really easily, but I also make sure that I check to make sure there's been no updates. So that's a really good site to have bookmarked. The other thing that we recommend is that all practices in Victoria subscribe to the Chief Health Officer alerts and advisories. So this is all of the things. So we've got measles case at the moment. So if you subscribe to this, your practice will get an email telling you that there's measles around and you need to be looking for it. Anything that's going on, you know, hepatitis A, we've had deaths from hepatitis A. All of this is on these alerts and advisories. And we also have the, oh, sorry, this is not my computer. So I'm just trying to scroll up, mine's at touch screen. So this is for men who have sex with men. So they will have things such as oh, here it is, this. So in Victoria at the moment, we have 4 vaccination programs going on for men who have sex with men. So at the moment, these are time-limited, state-funded programs. So it's only for people in Victoria, but we have a free hepatitis A vaccine for men who have sex with men. We have free meningococcal ACYW. So for men who have not had a meningococcal C vaccine within the last 5 years, which is probably most men, they can get this vaccine. All these programs go to the 31st of December. And then we also have a free Gardasil program, free HPV vaccine for men under the age of 26. They're eligible to have the free HPV vaccine. So these 3 programs are time limited till the 31st of December. And then we have an ongoing free hepatitis B vaccine program for men who have sex with men. We also, and this is all sitting under the Chief Health Officer advisory, there should have been lots of information that has come out to you, I am hoping, to let you know about this, but this is the information that you will also get in the newsletters. The other thing that we have as a time-limited program at the moment is for injecting drug users, and so they get free hepatitis B vaccine. That's an ongoing free vaccine for those people, but they're also getting free hepatitis A vaccine at the moment. So anybody that's injected in the last 12 months will be eligible for that free vaccine. Hepatitis A, again, going till the 31st of December. So it's really worth knowing about these things. The other program that's just been announced is the free under 5 flu vaccines for children. Really important that you are up to date with what goes on for this. So they will let you know what vaccines are going to be available. But what we have to think about is for children under the age of 5 that are having an influenza vaccine for the first time, they need to have 2 vaccines 4 weeks apart in the first year that they have it. Okay, so you're going to get a number of children that will never have had that vaccine before. They need to have 2 vaccines in that first year. For children under the age of 3, we need to be using Flu Quadri Junior. We need to be using that paediatric vaccine. Really important that they're getting that. As I said previously, the Afluria Quad is only for people over the 18, so we don't want to see any under 5s getting Afluria Quad. And I know for a fact that we were getting notifications to air all over Australia of children under the age of 5 having Afluria Quad. They shouldn't. So please make sure that everybody understands. Often it's a data error, so sometimes it is just that they've ticked the wrong box on the clinical software and it's just been transmitted up to air, but other times it actually was the wrong vaccine being given in the wrong age group. I'll just do one more. And then the last one. So the other website, which I haven't actually downloaded, is MVEC, so MVEC, and that's the Melbourne Vaccination Education Centre. They have a lot of online resources for you, but the other thing that they do is they do usually twice yearly updates. So if you're looking for an immunisation update, it does cost, but they have some really good speakers. They do whole day updates. This year they will only have one update because there's the National PHA, the Public Health Association conference on in June. So they'll only have one update this year for Melbourne. And then the other site is, if I can find it, oh, it's making, is the Immunisation Coalition. So this used to be the Influenza Specialist Group, if anybody had ever heard of the ISG. Oh, gone up too far, sorry. They have this fantastic resource. They have lots of really good resources, but this is the one I really like for general practice, for influenza. So it's actually a guide for influenza in general practice. Gives you all the stats you might need for patients. So it tells you how many cases that we had in Australia. When people sort of say, oh, it wasn't that bad, you can actually say, well, I can tell you how many cases we had, how many hospitalisations, the older people. So 91% of all deaths were in people over the age of 65. If you ever need statistics to help those people have their decision about whether having their flu vaccine. Though I think we've done a pretty good job with the over 65s, because I've heard they're sort of banging down the doors of a lot of general practices already saying, when are you going to have the influenza vaccine? We should have had it by now. The season has actually sort of moved over time. So we used to always give the vaccine in March. I think the year we decided we were going to give it as of the 15th of March every year, so everybody knew, then they decided that actually the season's probably running a little bit later. So we're now giving them in April. We do know that there's slight waning immunity, and this is why we're looking at having these highly immunogenic vaccines for the over 65. So they're going to get one of two vaccines. One's highly adjuvanted and the other one is highly more antigens in it. So we've got all of this information. There will be information. This is why I say subscribe to the newsletter, because as soon as we've got information about those vaccines to talk to your patients about, that will be there. We do know that people will get vaccinated if their doctors recommend it. If the doctor or the health professional takes the time to recommend the vaccine, people are far more likely to have it. And if you watch any of those current affair programs or projects or whatever, these poor people that come in and say, my child died of meningococcal because nobody told me there was a vaccine I could pay for. I would have had it. I mean, hindsight we know is a wonderful thing, but it's also health professionals have an obligation to tell people about these vaccines, not your decision about whether they can afford it or not. It's actually up to the parents to make that decision. And I heard of a practice the other day that had parents brought in 4 children, and they actually put them on a payment plan so they could all have meningococcal B, so they could just pay it off, because how could they say no, you can't have that vaccine? Then on the back of this handout is who should be vaccinated and why. So if you've got, you're not feeling happy about telling people about the fact that they're pregnant and they need to have influenza vaccine, it can give you some statistics and a bit of a hand with that. And we really need to do a better job of making sure that all our pregnant women are getting the pertussis vaccine and the influenza vaccine in pregnancy, because they are protecting their baby by having that then. And also we know that women that get influenza while they are pregnant have a much, much harder time of things, and we certainly learnt that with the swine flu. So that brings me to the end of me talking at you for nearly 2 hours.